Good evening all. Hopefully you can all see me and hear me. Do the usual, just click on the little tick or the cross or say something. Just want to make sure that everyone's got a good connection and can... Brilliant. Yes. Right, excellent. Okay, we can stop that. We can take it as given. Right, it's really nice to see so many people participating. I think I've just counted through, there's about 20, 25 people engaging here. I'm sure we'll get many more as the evening progresses. I'm just going to do a quick introduction and explain how the webinar is going to run this evening. It's really nice that we've got Alex Robinson, who's going to lead on this session looking at 4DCT. I'm not going to stand on his toes here and explain anything about the role of 4DCT other than to say it's becoming increasingly important and lots of centres are starting to use it for different sites. So as we go through, I'm going to take a back seat. I'm going to turn my video and talk off. And as we go through, if you have any thoughts, if you have any questions, just type away as usual. Excuse me. I will try and keep tabs on those so that Alex can focus on his presentation for the first 20-25 minutes. And then if Alex doesn't see them, I'll raise them again in the discussion afterwards. But just feel free to participate in the discussion as it goes. Okay, I've no doubt that Wilma will make a noisy appearance at some point. But if I keep my talk button off, you won't hear that, and it won't disturb Alex. Okie dokie. Right, so Alex, over to you.
Hi everyone. It's great to see so many people here, and it's really nice that Rob's been able to put all these sessions on because they really are quite vital for us all. It's nice to be able to have a chat about some really key points that's occurring in image-guided radiotherapy. Just let me know if everyone can hear me okay. I can't do much about the accent, but hopefully the volume I can play with. Cheers then. It's lots of effort. So today I'm going to look at 4D computed tomography. To give you some kind of background, I joined Sheffield Hallam a year and a bit ago. I suppose it's come on for 2 years now. Previously came from Leeds, where I worked in their pre-treatment department for 7-8 years, I think it was. Scanned 4Ds as if it was a routine kind of thing that you could do with your eyes shut. So I've got lots of experience in that area, and hopefully we'll be able to have some good discussion and conversation about it. So to give you some idea of the way that this session is going to go, I'm going to have a look at why we need 4D. Okay, I'm going to do a very quick revision on actually how a CT scanner works, because I know that for some of us it'll have been a while since we looked at X-ray tubes and things like that. So as I say, we'll briefly touch on that. I'm then going to go on to some department examples. So as I say, I've got lots of experience from the department in which I was in, so I'm going to share that with you and look at the ways that we can use 4D in the radiotherapy pre-treatment. I'm going to be looking at how we actually get the 4D data, what happens to that data once us, the radiographers, have completed the scan, and I'll very briefly mention some of the other techniques that are also out there. And then, as always, we'll have a nice discussion. Any questions, as Rob said, please feel free to type away. Being a typical man, I can't generally multitask, but hopefully someone will pick them up as we go through. So, why we need 4D? So, if we consider with radiotherapy, ideally what we want to do is give a high dose of radiation to a very specific area. We obviously know we've got our GTV being our tumour. We then add our margin for microscopic spread around that, and then we have this area of our PTV. So our PTV is normal healthy tissue, and obviously the more of it we irradiate, the more side effects our patients will receive. So ideally what we want to try and do is to minimise this, or another way I suppose looking at this is to make sure at least it's accurate. If we end up treating a patient and we don't treat all of the CTV due to the fact that it moves outside of our planned PTV, then we're going to have issues later on down the line. So it's really important that we can get this as accurate as we can. So when we look at our general CT scanner, okay, the majority of us will be using Hexial scanners. So consider that our CT scanner is going to take an image, a bit like a corkscrew or an apple peeling as we go through. Now, on a average CT scanner, we can do a CT of the chest, of the thorax, in easily 10-15 seconds. We then look at that data and the doctor contours his structure. Now, the structures that the doctors contour is showing that tumour at one given point in time. So we don't actually know if that's on inspiration, expiration, mid-piration. We don't truly know. So what we've previously done is use generic historic populated data. We've presumed that, if we're looking at the lung, for example, as we breathe, we can all predict that as our diaphragm is moving in the supinf direction, we could expect to see a larger supinf direction. So the number of our protocols tend to predict and place a larger margin on this. However, at the time, we didn't have any true facts or data on that. So what this image here is a great example from this. So this one across on the left-hand side, this one here, shows our tumour that our doctor would have contoured. So they'll have contoured around that, but they'll have then added the margin for internal motion. Okay, when they're following our ICR 60 guidelines, we know that we've got this generic setup error from radiographers due to our tolerances on, say, our lasers, on our isocenter. We know we're going to get some axial variation as well, but we also know we're going to get this breathing motion. Now, if we then have a look across on the 4D CT, you can see that now this tumour volume has drastically changed shape. And previously, this may have been in our volume that was generically populated from previous data, or it may not have been. Okay, so this is our concern. This is the reason why we need 4D, to ensure that we're always going to have this volume in the tumour site located within our volume. So when we look at 4D, we have to consider that, as I previously said, we want to give these high doses to certain areas, especially when we start looking at techniques such as SAVOR. So if we're trying to get ablative treatment, we literally want to minimize the amount of normal tissue as we possibly can. So that's the requirement of 4D. So when we look out there on 4D, it'll be interesting to see from all the people that are here today to see how many departments actually have 4D and are using it routinely. Okay. So there are other options on 4D. As I mentioned, that our CT scan takes 10-15 seconds for a scan of the thorax. Obviously, we could get our patients to go for the active breathing, to hold their breath, deep inspiration, and then do our CT scan. But trying to then reproduce that on treatment is very difficult. We do get this dose rate issue, that if we, on our linear accelerators, if we start our treatment, then interrupt, let the patient breathe, start again, we'll see that our dose rate never actually reaches the peak. And this is what our planning systems have planned the data from. So we have to take this into consideration. So very quick overview of a CT scanner. So up here at the top, we have our X-ray tube, our source. Beneath it, we have this panel of detectors. And what occurs, as I'm sure we're all aware, is that this rotates around our patient. And as it rotates, our patient then travels through the center, nice and simple. So what we have to look at is what things we can change on our scanner to get the best quality of images for radiotherapy planning. So let's start with this KVP. So this is the kilovoltage potential difference, which is applied to our focusing cup. Okay, this is our accelerating force. And there's a direct link between our KVP and our Hounsfield units. So in general, across the world, everyone's scanner will be at 120. So we can't do anything about that. Otherwise, we'd have to keep recalibrating our planning systems, and then obviously the probability of us forgetting to change it is out there with human errors. We also have our MA. So our MA is the electricity to our cathode. So obviously the more MA we put into it, the hotter it gets and the more electrons are produced. The more electrons there are, the more likely there is for an interaction with our anode to occur. So the other thing that we can do is our gantry speed. Now if you remember, when we're looking at our X-ray tube, the slower that this rotates round, the less radiation it will emit to our patient. However, the slower it goes round, it also allows for motion to occur. And what that gives us is artifact. It doesn't give us very clear images. And this is a slow CT is really the very start of 4D. We used to do slow CT and literally show this tumour as a blur move through the scanner to get this idea. The other option that most departments now use is the pitch. And the pitch is the speed in which the bed travels through the bore of the scanner. So the faster the pitch is, okay, obviously if we consider this as we've just peeled an apple or a slinky, if anyone can remember those. So if we increase our pitch, what we're doing is extending that. So we get larger gaps in between each part of our image. If we reduce our pitch, what we're doing is essentially pulling them closer and closer together. So on the 4D, the general way that we do it is that we leave the gantry rotation at the standard setting, and the thing that we adjust is our pitch. So by decreasing, as I say, by pushing that slinky closer and closer together, what we essentially get is oversampling of our target, our patient. So for every time that the X-ray tube rotates about our patient, we would like them to complete a full breath cycle. Okay, so we can imagine that sometimes we have to overpopulate because of the speed that this rotates around the patient. That's not enough to complete a full breath cycle. So this oversampling gives us this data, and essentially what we're going to do is 12 CT scans all at once at different phases. Okay, now something that's really quite key to consider this is the increase in this pitch from 1 to 1.5 decreases the dose. However, if we reduce the pitch, okay, so we're pulling these, we're now oversampling, once again, we're increasing our dose by 33%. So we do have to consider that obviously dose is a factor, and a lot of people, when they're considering 4D, always put time as an issue. Now, I know that on the Siemens scanner that I previously was working on, one of the safety features to ensure that we never overheated our anode, causing our tungsten and copper target to crack, and to ensure that we never overheated our filament, was that the scanner wouldn't be allowed to be on for longer than 90 seconds. Okay, so that is considerably longer than a 10-second scan. However, 90 seconds still isn't a long scan if we really consider the time. The thing that takes the time is all the setting up of the 4D scans, and I'm going to touch onto that in a bit. So, as I say, nice and simply, all we're doing is oversampling. We're getting lots of data. What we then have to do is tell our computer system that once I've done the scan, once I've oversampled, once I've done these 12 CT scans essentially at the same time, I then say to the computer, what I'd now like to see is a set of axial images where the patient is at 100% inspiration, 100% expiration, so on and so forth. And that gives me lots of information where this tumour potentially could be to get this internal tumour volume, which is referred in our ICR 60 report, to ensure that we can always know exactly where it is. So the current sites that most departments are now using this on, that have the option, predominantly is lung. We can clearly see that because the lung sits superior to the diaphragm, this contraction and reflection of our diaphragm causes our lungs to move quite a lot. So there's that uncertainty. We also have the pancreas for the same reason, that it's inferior to the diaphragm, our distal third esophagus, and any stomach or lymphomas of the lining of the stomach that we may treat with radiotherapy. All of these cause a motion that historically, as I mentioned, we used to use populated data to essentially guess where the tumour is going to be. And generally, we're not that keen on guesswork in radiotherapy, especially as we start to increase the amount of dose we're given per fraction. Obviously, in the future, another area that we could start to look at would be our liver, especially with the oligo-meds. So that's something to consider as well. So I'm now going to focus on the 4D equipment I've got the most experience with. Okay, so with the Siemens system, okay, what it uses is a pressure pad, a pressure sensor, which is this thing up in the top right. So this is placed onto the patient's skin using this elasticated belt onto the area of the patient which moves the most. So once the patient's laid on the bed and they've been breathing for a while, you can see that part of the diaphragm, that part of the abdomen that's going to move. Okay, so we try and place this at that point. Now we have to consider that to get the most accurate dosimetry, this will create some form of artifact. So ideally, we do not want this on our lung volume. The other thing you have to consider is that if I put this directly onto where my tumor happened to be, then I'm going to get variation in axial slice separation due to this belt. So we do have to consider its location. This is connected to this box over here, which is the computer software, which essentially is then connected to our CT scanner as well. So that's the setup. You can see that the patient on this patient is just having standard radical lung treatment. They're not having a saver treatment due to the fact that we've got no increased immobilization. There's no vac bag there. So that's what we're using at the moment for. So once this is set up and we've chosen our tattoo positions, we've chosen our scan limits, we then look at this tracer, which is this down in the bottom left-hand corner. So the tracer shows this dominant peak and a dominant trough, and this is the patient's breathing. So as they breathe in, they put pressure on that sensor and it gives us the spike. As they then breathe out, it drops as the pressure is relaxed, and that's the expiration. Now along the top here, we have respiration rate per minute, so the amount of breaths per minute that the patient is taking. And then along the bottom, what we have is time. Now at the moment, you can see that we've got these grey lines along the scan. Now this is currently showing us where 40% inspiration is on the patient. Now once the scan's done, all the computer system essentially does is it goes through and it chooses to only look at the axial images at these given times. Okay. Now it's quite important that our patient does get this regular breathing motion, and a lot of people often consider trying to train their patients, giving them coaching. Now the only issue is that essentially if we're training a patient to breathe in that certain fashion for the pre-treatment scan, then that should then be mirrored when we start the treatment. Otherwise, we're just causing inaccuracies, variabilities between each of the procedures. So generally, we'll just ask our patient to breathe in the normal fashion. Obviously, we have to consider that these patients will have had diagnostic scans where they will have been told to hold their breath. So it is important for us to, make this rationale between, do we get the patients to breathe? Do we coach them, or do we just ask them to breathe normally? Okay, so these things that we do have to consider. So, as I mentioned, what the scanner then does is it pulls the information together. So you can see on this slide here, the red slices, okay, all then get collated and get pulled into one aspect, the next slide and so forth. At Leeds, they did it for 12 phases. Okay, some departments do more, some departments do less. Essentially, it doesn't make a massive difference. Okay, the patient's not getting irradiated more, they're not getting irradiated less if we do the phases. It's just the amount of data that your department wishes to take, and we have to consider that, essentially, if I'm doing 12 CT scans, that's 12 times the amount of data that I normally have. That's going to be input into our planning system, which can cause them to drastically run slower, the contouring system, and the fact that we have to hold this data. So, there's, once again, rationale between having more or less. Now, what we often get is that this system was designed by engineers, and they put onto the bed their QA phantoms, and it shows these beautiful peaks and drops, each one very dominant peak, very dominant trough, and each one goes essentially the same. And they always struggle when we used to send the data off to them and say, well, actually, what we've got is this. They always seem to forget the fact that, you know, the most of these patients have got this thing called lung cancer, and it's preventing them from breathing in the normal fashion. Okay, so the issues that we get is that essentially, if as the scanner, as the X-ray tube is rotating around our patient, they have moved through without completing a full breath cycle, that means that we've lost data. So we need some way of checking how we can a way of checking if we've lost data. So along the bottom of our carbon fiber couch, there was a carbon fiber rod that just ran diagonally from one corner to the other. Now, essentially, if I've asked it to look at all the slices on 100% inspiration and then stick them all together, what we should get, if the patient has breathed regular and we haven't lost any data, is this perfect straight rod. Okay. Now, if there's a loss, if there's a break in the rod, what that is an indicator of is that the patient has maybe held their breath so that they haven't completed that cycle, or they've coughed, they've sneezed, or they're breathing too slow. Okay. So here we can see some of the problems. This is the breaks in the rod that I was referring to. Now, what the computer system does, people often refer to it as a break in a rod. It's not essentially a break. If we kind of really focus on this one down here, the computer knows that we're lost, we've got no data there. So what it does is it copies half of the next slice and half of the previous slice, and we get this rod that doesn't quite meet. Now, essentially, if that's not where the tumor is, then it's not an issue. So this top one up here, what they refer to is ghosting. So you can see along this top edge, we've got a blurred line where they've literally just mirrored the same slices. So we can see where the tumor is, we can see where the break in the rod is, and we can see that that's not a clinical, it's insignificant. However, if we start looking down on this lower one down here, and you can see that along this rod, there's multiple breaks all the way along. You can then see that there's this real ghosting effect, and unfortunately that happens to be where one of our tumours is. So that is a significant loss. Now, we've got to consider, if it's got loss, then we can't plan from it. That data isn't usable. And we then have two options, okay? One is to repeat the scan using exactly the same settings as it was before. So if halfway through the scan the patient had sneezed, then I'd have said that was a one-off occurrence, and if I repeated the scan, the likelihood of them sneezing in that area again would be minimal. So I could justify that repeated 4D scan. However, on this patient, as I said previously, you can see that there's multiple breaks all the way down the rod. So that's saying that even if I repeated it, the likelihood of that occurring again would be quite high. And then what we're looking at is 4 or 5 times the dose repeated. Okay, so essentially what we could do with the Siemens system is do a slow breathe scan. Now the slow breathe scan, the gantry remains at the same speed. The only thing that we do is we do a reduced pitch. So because the bed now essentially is moving through slower and slower, literally snail's pace, that means that the length of our scan is reduced. Because as I mentioned before, the scan can only be on for 90 seconds. So if we're unable to scan the entire lung due to this 90 seconds, then once again, we're not going to be able to have our volumes for planning for our DVHs. Okay, so there's another thing to consider. Essentially, if you could get the 4D scan done around the tumor alone, and then do a plain forward CT, then essentially you could fuse the two together to get your DVH, get your dose restraints accurate, but still get this ITV, this motion of our tumor. So contouring. So we've now done our scan. The data has been separated on our computer system, and we've got essentially 0% inspiration, 100% inspiration. What the doctor or the consultant or the radiographer is going to do is load up one phase at a time and contour around the volumes. They then load up the next set of data and see if the tumour moves outside that volume. If it does, they increase the margin. And this goes on and on and on. Now, at the start, what this would mean would be 12 CT scans that they'd have to contour. So you can imagine the time constraint on that is very, very high. We've also got the fact that physics would have to QA the data. The system was using that pressure pad that was placed, the sensor on the abdomen. And we have to take into consideration that abdominal pressure may not be a direct reflection of the diaphragm motion. So that has to be checked. Another one of our issues that comes across with 4D is IV contrast. So generally in all the radiotherapy departments, our timings have been taken from diagnostics. Now, when you go and speak to the diagnostic radiographers and you say, what I'd like to do is a scan which is actually going to take longer and expose the patient to higher radiation, they look at it as if you've lost the plot slightly. So the timings that we'd usually use for, let's say, a pink of 3 mils per second would be 30 seconds. However, if we've done a reduced pitch and so the scan time is going to be longer, essentially all of that contrast could have been injected through and then filtered out of the body prior to it getting to the area of interest. So it really means that we have to have good relationships with our contour to ensure that we know whereabouts the doctor wants his contrast, so that we can adjust the IV delay to reflect that. So whether we're looking for brachial plexus, so if we want to highlight our subclavicular artery, or if we are looking for pericardium, these things we have to take into consideration. Now, with the contouring, as I said, historically what we used to do was each phase. However, now with these maximum intensity projections, computer systems have algorithms in them which will allow us to contour the first phase, and it will then start to automatically contour the next series of images. So this can be really, really beneficial for us, really time consuming. So as you can see, this is our first GTV. This is then GTV 100, and we then use the MIP system, to produce this contour, the ITV. Okay. Now, once we've got the ITV, note that we still have to add the additional margin due to setup error, due to actual variability. So these factors still have to be included. However, what we're getting is a true reflection of where our tumour is going to be throughout the breathing cycle. So other systems that are out there, I know that Varian use an infrared system. So what they essentially place on the patient is a tube which uses infrared beams to detect the motion. Okay. I'm not sure if the Varian system allows to do a slow breathe scan. Maybe someone could let me know on the discussions later on. The other thing that we can do is restrict it. So this literally, it tends to be an abdominal compressor. So on the abdomen, they place usually a polystyrene subject, okay, onto it to literally minimize how much the patient can breathe. Okay. The compliance issues are quite high. We have issues whether we're looking at the infrared, the abdominal pressure, or the restrictor. Some patients, it doesn't matter how long you try, you just cannot get the perfect data set on. And there's not much we can do about that. CyberKnife is the opposite end. The CyberKnife would be able to take this into consideration due to its continual tracking system. However, it's not commonly used within the UK. So that brings me to the end of the presentation. Hopefully Rob's been taking down lots of questions for me, because I'll be honest, I haven't even glanced across. If anyone does have any questions, please let me know, and I'll give you some answers. Hope this has been beneficial to you all.
That was excellent, Alex. Thank you very much. There was actually fewer questions than I thought as we went through, but I'm going to try and summarise. Yes, I'll turn my thing down.
Oh, it's probably me, Rob. I'll turn the voice off.
You might want to turn it back on in a minute when you explain things, but I'm going to start with something that Ben raised, and I put a point here. I asked whether MIP, maximum intensity projection, was was something that most people used as a way of generating the internal target volume. Because I think most people do, but those that perhaps don't work in pre-treatment, or those that are in the process of implementing 4DCT may not know much about it. So, do you want to just explain a little bit more about MIP and the process that's involved?
Okay, Rob. So, depending on your planning system, it really does decide which system you're going to use. I know at Leeds they used GE Advantage Sim, which didn't have MIP, so they were restricted in the fact that they had to contour each phase. MIP looks at the maximum intensity of a given area. So when we're contouring, we can select certain voxels of our tumour, which when it then loads up on the next phase, it looks for these similarities. So it will then automatically contour the next aspect of it. I know that it is available on the Eclipse system because I've got experience with that, and it really does, it's not always perfect, and it does need a little bit of fine-tuning around it. However, it takes out so much time. With the GE scanner, with the Advantage Sim, another option that it does allow us to do is to play in this cine film, and I'm sure I can do that on the Eclipse system as well. So that'll allow us to play it, to move it along. But essentially, as things start to improve, as our computer systems and the algorithms, and hopefully the cost starts to come down, everyone will start to be able to use MIP to get it easier. Hope that helps.
That's great, Alex. Thank you. Ben saying, would MIP be covered on the contouring course in May? I guess so. And one or two people have made comments here that, just to echo what you said there, Alex, in that it's not perfect, and they then use a movie loop to check. So there are ways of sort of, it's just a time-saving device. And okay, there was one or two points. I'm going to start with I think Vivian raised a point earlier about coaching and the requirement for coaching for 4DCT. Some people do, some people don't. Interesting to know your thoughts there, Alex.
Yeah, so it is an option. As a pre-treatment radiographer, it would have made my life, and essentially at the start we did, made my life a lot easier, because you're forcing the patient to get these very dominant peaks and then very dominant troughs. So when we were looking, I'll try and draw this. So when we're looking at these peaks and troughs, if we get the patient coached, essentially that is what we get. Okay. This then gives us, as I say, this maximum inspiration and this maximum expiration. But realistically, if I get a patient and say, what I want you to do is to breathe in, what they do is they go, and they fill their lungs with more oxygen, more air than they essentially would do on a normal stage. So although we get this ITV, it may not be a true reflection of what occurs on a regular basis. The other thing that we also have to consider is that if we're trying to use a 4D scan in an attempt to shrink our volumes, then we also should be looking at how we can verify this. So really a 4D XVI, 4D CBCT, should be considered as well, to ensure that no matter what we do, we can track this system.
there were some comments. I think it was Bev that talked on about slow breathers and scan time.
Yeah. Well, so the slow breathing patients, as I say, that if the pitch is still too fast, so that I'm trying to get over sampling on my scan data. If the patient breathes too slow, it means that I haven't got over sampling. I've got a break of data. So all I can do is get my bed to move slower. Now, this is going to increase the dose to my patient. And if there is a restriction, like there is on the Siemens scanner, of how long the X-ray tube can actually be irradiating for, it causes a reduction in scan length. And obviously, if we can't get a full volume of essentially our lung, then it makes it very difficult to plan from. Another thing that we have to consider is that because of the reduction, we've got an increase in dose and an increase in data. So the more our radiotherapy planning systems start to use fused images, start to use additional scans, at some point we are going to get issues with memory. You know, we need to be able to store this, and it has a knock-on effect of everything else that it just creates this slow time. I've seen some departments that when they recon their 4D patients, it really takes a considerable amount of time. Now on the Siemens scanner, we were quite fortunate that it would recon in the background and we could still scan over the top. But I know that there are a few departments that will wait till the end of the day once they've finished scanning to then recon. So, you know, we have to really consider these things. What do you think, Rob?
No, that sounds good to me. Something I was going to comment on in relation to pitch and breathing is that are there issues of you can get artifacts, I think, if the tumour motion is fairly similar to the pitch and gantry rotation speed.
So artifact is an issue. The easiest way for us to consider this is if we consider a normal CT scan to start with. So on the CT scan, the easiest way to look at is the diaphragm or the heart. So as it goes through, you get this artifact of motion, a bit like an old school camera where you take a picture, and if the shutter speed was really slow, you get this blurred image. Now, essentially, if you get, as Rob said, if your X-ray tube is rotating around at the same rate as which the tumour is moving, you get essentially what looks like a slow breathe or a slow CT scan. So that's where they used to just slow the X-ray tube rotation down, okay, and you'd get this artifact. The largest areas would be along the heart, the diaphragm, but also our exterior contouring, our axial variations, which then makes it very difficult when we're looking at the effect of the inverse square law for planning and our FSDs, SSDs, whatever you want to call them.
Brilliant. There was something on there about it's hard to keep up. Danielle.
Okay. If we're looking at
sorry, Alex.
If we're looking at time. It's all right, Rob. So if we're looking at time for how long it takes to scan and set up a patient, the setup time is exactly the same as it would be for a conventional scan. So just before I left, I'd be able to do a 4D CT lung patient in 10-15 minutes, and that's from walking them in, getting them changed, getting them on the bed, to the scan, the tattooing, and then out. The only thing that we have to consider is that before we let the patients leave, obviously, as I said, the scan's relatively quick, it's only 90 seconds. But before we let the patient off the bed, we have to make sure that we've got all the data that's suitable for the planning. So this does mean that from the end of the scan to where we get them off the bed is increased. But at the same time, we used to use this, this time would be useful for when we were giving saber treatments to lung, because we were aware that we used to do a XVI scan, CBCT at the start, halfway through and the end. Due to the fact that we're giving a high dose in a single fraction, or a high dose per fraction, sorry, they'd be on the bed a lot longer. So it used to be quite good to make sure that our patients were able to withstand that length of time in that position. Okay. Yeah, you're right, Rob. It's hard to keep up with these questions.
You can see this here now. I think this is the Taunton posse here. What sort of side effects have you been encountered to prevent continuing? Separate free breathing scans. Yeah, I think one or two people have talked about addition of free breathing scans and the extra dose, and whether that's a consideration.
I've noticed that there's been the odd comment on the deep inspiration breath hold technique, and I would be interested, as I say, to see in these times what the dose rate you were predicting to have and what it actually gets to during treatments. I would be interested to see how close it gets to. I know that in some departments we were expecting a 600 dose rate, and due to the fact that their treatment times tended to be 20 seconds, interrupt, breathe, 20 seconds, and so forth, that the dose rates were only getting up to about 400 at the very peak. So it'd be interesting to see the comparison in, yes, we've produced this plan, and we've managed to reduce heart volume, we've managed to reduce lung volume. However, is this actually a true reflection of what is occurring with our patients?
Type away, people. Okay, well, what people are sort of inputting some information there, because there seems to be quite a variation already. We've got 300 monitor units per minute, 60 monitor units per minute, and it varies from around 500-ish. I'll come back to this. A question for you, Alex, because your experiences with using the compression band approach for 4DCT, I'm not familiar with it at all, so I've never seen that used clinically. But are there any patient-related issues that affect its accuracy? So I was thinking off the top of my head, I'm wondering if whether patient obesity or other characteristics might affect how good it is.
Okay, so let's try and find our slides here. So we can see that on this slice, Rob, we've got this this elasticated band that goes around our patients. Now, what we tend to find is that as our patients their body mass index does start to increase, you really struggle to see the diaphragm, abdominal motion due to breathing. Obviously, due to the fact that we've got both external fat and internal fat, which is pushing our lungs really superior. So sometimes we do really struggle trying to find this tracer, this thing at the bottom. Now on the system, we do, it'd be lovely if this is how it turns up. However, it never does. You have to change your settings, and you've got amplitude, and my mind's left me what the other thing's called. But either way, we can change this to try and increase the peaks, but sometimes you just cannot get it. The other patients that you have to consider, Rob, is actually when we think about lung patients, often it's due to smoking and due to patient age. The older they become, the more likely they are to get lung cancer. So we get quite a few of really skinny patients where you actually get, where they're in for their Ziffy, you get this hollow. So when you're trying to put a band around and there's this hollow gap here, you don't get compression. So you end up putting the belt so far in that you're not actually getting diaphragmatic motion. You're just getting this abdominal motion. And then you've really got to query, you know, the rod will be nice and straight, but the data, you know, I'm not convinced that that is a true reflection of tumor motion. So it's a very valid point, Rob. It'd be interesting to see with the infrared system if you have the same issues, because essentially all we've put this direct connection between abdominal motion and diaphragmatic motion. And, you know, that's obviously we do it because there's no other method. Okay. However, there may not be that correlation.
No, that's a good question about the RPM system. Have we got people here in the webinar tonight who use the RPM system?
So, Danielle, you put up your question of would coaching to utilize more abdominal breathing techniques help? So what we have to consider is, yes, it helped me as a pre-treatment radiographer to get my scan, but we have to consider it as the whole process. So, you know, yes, I could get that, but that's not going to be a true reflection of then their daily treatment. So then I think we're just doing it for purpose sake, and I'm not convinced that that's the way that we should be considering this. Okay, but you're right that if we could get the patients to coach and then to monitor and mirror that coaching through their treatment, then essentially that could help. One of the other things that we used to do in Leeds for the odd patient due to their BMI, essentially when we couldn't get the data from our 4D scan, was that we would take them across to the LINAC and do a 4D XVI just to show the tumor motion, to see what its maximum suit position is, what its maximum in lateral and post, so on and so forth, and then just replicate this on a conventional CT, just so that our PTV, ITV is more focused around the patient rather than historic repopulated data.
Yeah, absolutely. I mean, that's the whole point really of 4D CT, isn't it? To generate individualized margins. Right, there's a couple of people who said that they do use the RPM system, Roz and Carolina here. So you two there, have you come across any issues in its use that have created concerns along the lines of what Alex has said in using the Elekta system? Where to position the box? Yeah, I mean, I think the most common place is sternum. Is that what you do, Roz? Or do you have to vary it for patients? And if so, how do you vary it?
I suppose that rather than considering the location of the box, as long as when we're doing our QA, we've seen that the most anterior of the box is on 100% inspiration, so when the diaphragm is at its most superior, then essentially it shouldn't matter. But it's just making sure that the two are mirrored so that there is this correlation between box location and diaphragm location.
Okay. Okay. Right. I may have missed other questions that people have put, but if you've got any issues or questions about 4DCT for Alex, keep typing away. We've got another 10 minutes yet.
Hiya Ben. So, as always, further software and the big old further licenses are required to do 4D CBCT. So it's, once again, it's all about the money, unfortunately. Maybe you could suggest a pay cut. Okay, Danielle, let's just start with this. So I mentioned earlier about the differences about ITV, PTV margins. So if we consider the ICRU 60 report, I think it's 60, we've got our gross tumour volume, we've then got our clinical tumour volume to include any microscopic spread. They then started looking at the PTV volume, and they actually separated it into different aspects. So part of that was this internal target volume, and this was showing where the tumour was going to move due to organ motion. From that, we have our patient setup, the fact that as well as our tumour moving, our organs moving, potentially the patient could also have a fidget. We've got the setup errors, which looks at our tolerances with our lasers. So essentially it's plus or minus 2 mils. So essentially our lasers could be off by 4 mils, so we need a margin to include that. Now, when we're looking at the differences, so we've got all those margins, when we're then looking at the differences between 4D and deep inspiration breath hold, is that deep inspiration breath hold is great for our breast patients due to the fact that as they breathe in, potentially we can increase the distance from our pericardium and our chest wall. Okay, so as well as meaning that we're then irradiating less of the heart, it also means that we'll always be irradiating the same volume of lung. Now, if we consider trying to do a deep inspiration breath hold with a lung patient who has already got minimal lung volume, due to the fact that essentially they've had surgery and they've either had wedge resection, lobectomy, pneumonectomy, then the likelihood of them being able to comply is the issue. And then especially as we then give them radiotherapy, we're going to cause inflammation. Okay, I think that's in essence, that's the reason why we would need a 4D rather than a deep inspiration breath hold. Okay.
Well explained.
Yeah, I think Andy makes a good point here. So when we're looking at 4D, we obviously have to try and predict which one we're expecting to see the most motion on. If I've got an apexial tumour, realistically, my diaphragm isn't going to influence that tumour much. So I certainly wouldn't consider doing a 4D CBCT scan on a tumour that's located quite high up. However, what we also have to consider is when we're planning it, we still want to try and minimize our the volume of normal tissue. So we can still do the 4D CT, but for verification, I'm not sure that'd be required. As you rightly then say, however, lower lobe tumours, anything that's really proximal to our diaphragm, definitely, if we're putting the emphasis on 4D CT, then why not do 4D CBCT? Okay, it's just a thought. Danielle, yeah, you're absolutely right. When we do a 4D CT, you are completely right that the images are the noise on them is worse. So we do get, it's always this, one thing increases and unfortunately so does the other, this seesaw effect. So yes, we get the motion, but it's then harder to truly verify, truly to see this, this data. I'm not sure if anyone can answer Ben's question there. Being pre-treatment, I stayed on the kilovoltage on the CT scanner, so I'm not actually sure how much longer a 4D CBCT takes comparison to a CBCT. Okay, so the benefits of having a fiance who's still a radiographer. So she's just said that it generally takes 3 times longer doing a 4D CT, 3 minutes. Well, exactly what Amy said, rather than 1 minute. So there is longer time, and obviously we'd have to consider, if we're truly going to look at this, is dose once again. Can we justify giving the patient normal integral dose more through a 4D CBCT?
Yeah, it's always a good point about the dose. I mean, clearly it's relatively insignificant compared to the therapeutic dose we're delivering.
Lung cancer patients and their survival rates aren't, we're not really going to be concerned too much.
But having said that, it's still, I think people often forget how significant the dose is from CT, and particularly cone-beam CT. From a diagnostic perspective, I think I'd rather spend a day having a look round Chernobyl than having a whole body CT.
So my fiance's come up with some other interesting points, is that when we're looking at doing a 4D CT, essentially, just because we've decided to do a 4D CBCT doesn't therefore mean that we're always going to do a 4D CBCT. So we'd have to justify that if we've done it on the first 2-3 days and we're happy with the motion, then we can't really justify that additional exposure for every other verification. So maybe we should be looking at doing 4D CBCT to start with, but then falling back to our traditional 3D scans.
Ben's made a good point there. I think it's something that's worth quickly exploring before we finish. Issues when thorax tumours shrink. Is there a need for a replan? I suppose the issue with 4D here is, if the tumour shrinks, to what extent is that likely to affect margins, I guess, and the individual motion associated with that tumour?
Another thing that we'd have to consider when looking at a rescan would be the method of treatment. So if we're doing a VMAT plan, essentially, due to the fact that VMAT has less of an impact with axial variation, then maybe we wouldn't have to do an additional scan. If we can, it all depends on where this tumour is, and you would definitely have to have conversations with the dosimetrists and physicists to actually see what impact that would have on the actual plan. Without a doubt, they'd have to look at that. And then essentially, there are these systems that are able to plan from the VCT. So yeah, I wouldn't like to say 100% one way or the other on that one, I'm afraid.
That's okay. I just thought it was a fair point. Okay, we're running out of time. In fact, we've run out of time. So first off, I'd like to thank Alex for his time this evening and his contribution. It's been really clear, very useful. I hope you found it informative, and the role that 4DCT is playing in both pre-treatment and also in the treatment arena as well for IGRT. And just a quick reminder about the tweet chat tomorrow evening. I hope you can take part in that. And also the webinar for next week, we are going to be focusing more on the evolving role of cone beam CT and adaptive radiotherapy. And Mark Collins is going to be leading on that, but I'll be here to host it and to try and get you to engage in some questions and answers as we go through. So thanks ever so much for everybody for participation tonight. Good questions?
Yeah, I'd like to do Rob's thanks. It's some of the discussions on there. I look forward to reading it back. It's been really, really worthwhile. So thank you very much, guys. Cheers. Cheers, Rob.
Thank you very much, everyone. Night, and hopefully see you tomorrow.